Next on primary care, eye disease, whether it's glaucoma, cataracts, or diabetic retinopathy. Like many other health conditions, African Americans are most at risk.
Glad I went. If I had ignored it, I'd probably be blind today.
Hello and welcome to Primary Care, the show dedicated entirely to the health and care of African Americans. I'm your host, Dr. Lonnie Joe. Did you know that African Americans have some of the highest rates of vision loss and blindness caused by eye disease? And those rates are continuing to rise. Here's some of the statistics that you may not be aware of. More than 825,000 African Americans have diabetic retinopathy. Over 520,000 have glaucoma. And nearly 190,000 have low vision or loss of vision. In addition, half of all vision loss in African Americans is caused by cataracts, a clouding of the eye that we're so familiar with. But vision loss can be prevented. Joining us today to talk about eye disease and vision loss is Dr. Bret Hughes. Dr. Hughes is a professor of ophthalmology at the Kresge Eye Institute at Wayne State University School of Medicine here in Detroit. He also serves as director of the glaucoma service at Kresge Eye Institute and is chief of ophthalmology at the John D. Dingle VA Medical Center in Detroit. Dr. Hughes, welcome to the show. So glad to have you.
Thank you very much, Dr. Joe.
Tell us, what is glaucoma, Bret? I mean, everybody has been touched by this disease. You either got it, or you know somebody has got it, or somebody's had surgery or gonna have surgery. What is glaucoma for our viewing audience?
Glaucoma is a group of diseases that affects the optic nerve of the eye. And the way I try to describe it to patients is if you look at the eye like a TV, and the optic nerve is like the cable that is bringing the information to the TV.
So if plug into the back.
Right, so if you disconnect that cable, then you lose the picture. So the optic nerve is damaged by this condition called glaucoma. Now, how is the nerve damaged? So the eye produces fluid naturally. This is a natural cycle where you produce fluid in the eye, which is separate from tears. This is an internal fluid. And there's a place for this fluid to drain. So as you produce fluid, if you continue to produce fluid and you don't drain the fluid, then it builds up in the eye. That increases the pressure in the eye, and the increased pressure damages the nerve. The problem with glaucoma is that this increase in pressure is not detected by patients or people who have this condition. It doesn't cause pain, it doesn't cause redness, it doesn't cause any of what we call the biological triggers that give us a sense that something is going on.
You may not even have vision disturbance.
So until the very end.
Right.
And so you lose vision in the peripheral of your vision slowly until it goes to the central part. When it gets centrally, that's when you start to recognize it. But at that time, you've already lost a lot of the peripheral vision. So that's why we try to give public service announcements to increase the awareness of the condition so that people can get an eye exam, because you'll never know unless you get an examination.
Is there any reason why some populations may have more glaucoma than others?
Yes. So when I talked about producing fluid in the eye, there's the place where you produce the fluid and the place where you drain the fluid. So this place where you drain the fluid can be blocked by internal structures, or it could be open and just not functioning well. So that's the difference with what we call open-angle glaucoma, which is more common in the African American community. And then there's an angle closure glaucoma, which is more common in Asians. So there's different types of glaucoma. The African American community, it's more common that we see the open-angle glaucoma, where the drain is open as we look at it, but there's some biological deficiencies that don't allow it to drain, even though structurally it is open.
What about risk factors or warning signs for glaucoma, especially open angle?
The warning signs, I'll address that first, there are none. And that is what we call glaucoma the sneak thief of sight. And so there's no warning at all. And the only warning that you can have is the awareness of someone in your family or having self-awareness, maybe I should get an eye examination to determine if I do or don't have glaucoma. Some of the risk factors that we look at for opening of glaucoma: one, African Americans are at higher risk. Latinos are at higher risk for opening of glaucoma. Age is a risk factor, and we're seeing age is a risk factor for a lot of things, and glaucoma, hypertension, diabetes, family history, and there is some genetic predisposition for certain types of glaucoma. So if you have glaucoma at a very early age, there are some genetic markers that have been found for juvenile glaucoma, opening of glaucoma. So those are some of the risk factors that we look at and that patients can be aware of. But then there's other risk factors that we as eye care professionals see on examination, such as looking at the optic nerve and how the appearance of the optic nerve, checking pressure. We look at the thickness of the cornea, which is the front surface of the eye. Some of those have been found in a lot of studies to be significant risk factors for the development of glaucoma, or if you have glaucoma, for progression of glaucoma. But those are things that patients will not be aware of unless they have an eye exam.
So with this thief lurking around, we probably, especially in the primary care community, should be one of the first line of defenses that talk about how we get people to eye examinations earlier instead of later.
I agree. So in healthcare professionals in general, we all should be aware of all the different things that could be seen, such as high blood pressure and diabetes. We can see that in the eye sometimes. As you know, diabetes affects the blood vessels, and blood vessels in the eyes are, there's really no different than any of the blood vessels in the body. So if the blood vessels in the eyes are affected, we should bring that awareness to the patient and send them to primary care specialists. But yeah, we should all be aware of the things that could, that can happen. Even if we aren't aware of some of the specific things, we should ask, have you had your feet examined, or have you seen your eye care professional? Or so we should just continue to raise awareness to take care of our bodies in general.
So if we were to advise people, routine eye exams should start approximately at what time, what age, especially if there's a family history, these kinds of things going on. That's kind of intuitive, but where should we be telling people at this age you really need to start getting an eye exam?
I would say at least in your 20s you should have an eye exam.
That early?
And just to see where you are, because even though glaucoma can run in families, it does skip generations. So you may not know anyone who has glaucoma in your family, but that doesn't mean that you won't develop glaucoma. So you can determine early on where you are at risk, because glaucoma is not the only condition that you could be affected by. And there's other things that we could find, and we believe that preventive medicine is the best medicine. So if we can see things early, then we can let you know some things that you can do to help prevent certain conditions. And then when you get into the 40s, if you're in your 20s and you have a normal exam, you can probably go 2-3 years, every 2 or 3 years. I think once you get to your 40s, in the African American community, I usually recommend maybe once a year. And when you get to your 60s, I think everyone should have an exam at least once a year.
Dr. Hughes, we're up against a break. Up next on Primary Care, hear how this 91-year-old young senior is winning this battle against glaucoma.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become 1 in a million.
Who's most at risk for coronavirus? People over 65, people with underlying medical conditions like heart disease, chronic lung disease, asthma, diabetes, people undergoing cancer treatment, and people with weakened immune systems. What should you do if you or a loved one is at higher risk? Avoid close contact with people, avoid crowds, stay home if you can, wash your hands frequently. Learn more ways to protect yourself and others at coronavirus.gov.
91-year-old Rudolph Dye credits his doctors and the eye drops that he's been taking for over 40 years for maintaining his vision.
My name is Rudolph Dye. I'm 91 years old, and I was diagnosed with glaucoma about 10 years ago. Well, I was working and I was having a difficult time seeing across the room, so I went to see the doctor to find out what was happening. And he did a lot of field tests, checked my eye, checked the pressure, and then he determined that the glaucoma was coming along slowly, and he controlled it with drops at first. And he controlled it with drops for about 10 years. And he retired. Then another doctor took over, and he continued the program with eye drops only. But then the pressure started building up. The plateau was 20, and below is okay. 20 and above is too high, and it could do damage to the retina, and you could lose your eyesight. So the last doctor couldn't do surgery, or he didn't do surgery, because that wasn't his specialty. So he referred me to Dr. Hughes. Dr. Hughes said I had to have surgery because the drops couldn't control it, because the numbers were so high. They were in the 30s. And you had to get it below 20. So he decided to do surgery on both eyes. 2 surgeries on this eye, 3 on this eye. And at first he had trouble getting it down because scar tissue would form. It would prevent the fluid from flowing out of the eye into the channels like they're supposed to. So he had to go back. It was kind of irritating because, you have to wait for it to heal. And it takes about a month to 6 weeks for the surgery to heal. And I kind of handicapped, really. And I'm used to doing things on my own, so I couldn't do it, so I had to depend on others. My son, people at church, they would drive me around, but eventually you get over it. But you have to get over it, because if you don't, you lose your eyesight. After he did the surgery, he said I was one of 5% of the people that, even though they get the surgery done, you have to continue doing eye drops. So I'm still using eye drops now, in both eyes. So I'm glad I went, because I've been doing this since I was 50 years old, under the care of an ophthalmologist. I'm glad I went. If I had ignored it, I'd probably be blind today.
Dr. Hughes, without surgery, Mr. Dye would have lost his sight. Is that correct?
That's correct. So with glaucoma, the goal of glaucoma is to lower pressure. With initial treatments, we usually start with eye drops. There are different eye drops that help to increase the outflow of fluid, and there's some eye drops that slow down the production of fluid in the eye. And those are our initial treatments. There are some patients that, in spite of maximum topical medical therapy, the pressure is still uncontrolled, and then we have to escalate. We have laser therapy, which helps lower pressure, and if that is unsuccessful, then we have to go to surgery, where we create a new drain where fluid can drain from the eye. Otherwise, the pressure being as high as it is, patients continue to lose vision. So at that point, we have to lower the pressure by creating a bypass, essentially, in the eye. And with this bypass, now fluid can drain from the eye, pressures are controlled, and we preserve vision.
Mr. Dye seems to be doing very well, 91 years old, having had what seems to be a successful outcome to his plan of treatment and his surgery. Speak a little bit about his need to continue eye drops after surgery and how he has done overall.
Yeah, Mr. Dye has gone through what I consider the roller coaster of treatment with glaucoma. So we'll start with eye drops. If they're not successful, then we progress to laser and then surgery. And then in many patients, or in some patients, even after surgery, they may need to continue to use eye drops in order to help control pressure. So in those patients who continue to use drops, a small percentage of those may need an additional surgical procedure. So there's always something that we can do. Mr. Dye is 90 years old, and he's had more than one surgical procedure, in fact, to help control his pressure. And I always tell patients there's really no age limit on vision. Everyone wants to see. So there's things that we can do to lower pressure to help preserve vision.
But obviously he's giving kudos and credit to his doctors and the treatment plan that was developed for him in order to maintain his vision.
Yeah, so Mr. Dye, one thing that is important, he does, he comes to his appointments, he makes each of his appointments. There's been studies that have been done. The patients who go blind from glaucoma are the ones that are non-compliant and don't show up for examinations, or they show up late. When I say late, late in the condition. So if you are maintaining your appointments and following instructions of the eye care providers, then the patient and the healthcare provider can put together a plan to save vision.
Now, he also had cataracts.
Yes, so I'm glad you brought that up. So cataracts, I try to tell patients, cataract is not a disease. Glaucoma is a disease. Cataract is an aging process that everyone goes through, just like gray hair. And the only way to avoid developing cataracts is to die young, and that's not a good option. So the longer we live, the more cataracts will form, and cataracts will form as we continue to age. So Mr. Dye is in his 90s. The average age of patients with cataracts are at a point where what we call they are visually significant, meaning they are having an effect on the vision and glasses won't improve vision, requiring cataract surgery. That usually happens on average in your 70s. But just like some people can gray prematurely, people can develop cataracts earlier, and some people don't develop them until later. So cataracts is something that everyone develops as long as they live, but then if you develop glaucoma, everyone doesn't develop glaucoma. So cataract and glaucoma aren't necessarily connected per se in terms of being a condition in the eye, but one will develop glaucoma. Living long enough, they will develop cataract as well. But even without glaucoma, people will develop cataracts.
Understandable, cataracts being a condition of age, but can occur in younger age groups.
Correct. And you can be born with cataract.
You can
There's
be
some
born with
congenital
cataracts,
cataracts.
yes, okay. So, treatment, remedies, options for patients with cataracts.
So first thing I like to say to patients is that cataracts are not a condition where they require surgery unless you're having difficulty with your vision. I hear a lot of patients that have been told they have cataracts, so that means I have to have cataract surgery. So that's not necessarily the case. Cataracts should only be removed if your activities of daily living are being affected and you can't be corrected with glasses. I have plenty of patients with cataracts and they see well enough to do the things they like to do, whatever they're doing. As long as they're seeing well enough to do the things they like to do, if they're driving, they still pass the driver's test, then you just continue on. But when it gets to a point where you're having difficulty either with glare, with driving at night if you drive at night, so cataracts will cause problems with glare, or cloudiness in the vision, and you're not seeing price tags, or you can't see the TV or reading magazines as clearly as you like, and it's because of cataract, then at that point, cataract surgery is required. So
what surgical options do patients have at that point? As I'm sitting here waiting for my cataracts to form with age, what options would I be given once my vision begins to become a real significant problem on a day-to-day basis?
So cataract surgery, there's different types of cataract surgery. There's laser cataract surgery, and then there's cataract surgery that we perform with hand pieces. There's a minority of physicians that do perform laser cataract surgery. When you look at outcomes at this point are generally the same in terms of what the patients are experiencing in their post-operative vision. So laser cataract surgery is marketed by a lot of physicians, but in terms of the outcome, cataract surgery, the traditional way versus laser, is 6 in one hand and half a dozen in the other. There are different types of lenses that are available as well. So the standard lens that we use is what we call a monofocal lens, where there's just one focal distance. You can see either in the distance or up close, and then you need glasses to supplement that. And then the other lens is what we have called multifocal lenses that do give you both distance and near. And standard insurances will cover the monofocal lenses, but the premium lenses, as we call them, which is the multifocal, are not covered by insurance. There's usually an upcharge for that.
We would not be worth our salt if we didn't talk about diabetic retinopathy, diabetes, the disease that's changing the face of medicine in this country. Talk to us about the prevalence and why African Americans, even though having diabetes for lots of reasons more than other populations, seem to have the complications that you don't want to see in that disease state necessarily.
So diabetic retinopathy is a condition, or diabetes is prevalent in the African American community, probably more so because of diet than anything, a lot of environmental factors and how we eat. And diabetes is a difficult condition to control because we don't want to change our lifestyle, basically, especially our eating habits. And diabetes, being uncontrolled, will start to affect all the blood vessels in the body, including the eyes. And patients who are either not aware of that or in denial of what this condition is and what it can do, because a lot of times you feel okay, even though your blood sugars are extremely high. The damage is occurring as they continue to live that lifestyle. And unless you are seeing an eye care provider or your primary care provider who can let you know the signals or give you the guideposts of what you should be maintaining, your blood sugars, hemoglobin A1C, unless those are controlled, you will start to suffer some of the end organ damage that can occur. And diabetic retinopathy is one of those conditions that will occur in patients who aren't controlling their blood sugars or changing their lifestyle as a result of the condition.
How soon will patients experience symptoms who are developing diabetic retinopathy?
Once you develop diabetic retinopathy, it's interesting. I see a lot of patients with diabetic retinopathy who are asymptomatic. And they can be asymptomatic even though I look into the eyes and see a lot of things that are happening. And they can be asymptomatic for a number of years. And not until it really starts to affect the vision, sometimes do patients become serious about the treatment. So they can go 2, 3, 4, 5 years, and sometimes even longer, with changes from diabetic retinopathy that they don't see in their daily lives, that they still have good vision.
So treatment in this terrible disease state?
There are a number of treatments now for the condition. So the number one treatment is controlling the blood sugars.
Exactly.
So that is the ultimate treatment for diabetes in the eye and the rest of the body. But for the eye specifically, there are laser treatments that we perform because the damage of the blood vessels, some of the blood vessels start to leak, and you have some hemorrhages in the eye. So they can be treated with laser treatment. And then some of our newer treatments, we have injections. So there are medications that we can inject into the eye that help reverse a lot of the changes that occur as a result of diabetic retinopathy.
Do we have any Star Wars stuff coming down the pike in terms of, what can we expect 3, 5 years from now in terms of eye treatment for these various diseases?
There are some, Star Wars type treatments that are on the horizon. There are patients who have digital implants, basically.
Digital implants?
Oh, I call them digital. They're
Wow.
implants, for lack of a better term, where you can have what we call artificial vision. The retina is basically a connection of cells that have an electrical connection that connect to the brain. So if you can simulate an electrical connection that is different from the retina and still have that electrical stimulation going to the brain responds to electrical stimulation no matter where it comes from. Mm-hmm. So these are some of the things that are being developed today.
That's amazing. That is amazing. So we've got a lot to look forward to in the treatment of eye disease in this country. Good. Bret, thank you so much for joining us. This has been outstanding. We'll have to do this again, okay?
Thank you for having me.
Thank you. Good. Our guest has been Dr. Bret Hughes, professor of ophthalmology at the Kresge Eye Institute at Wayne State University School of Medicine right here in Detroit, Michigan. He's also chief of ophthalmology at the John D. Dingle VA Medical Center in Detroit. There is still much to be learned about why African Americans are more at risk for developing certain eye diseases. But one thing is certain, early diagnosis and treatment remains key to preventing vision loss and blindness. So, getting the recommended eye exams are necessary for detecting glaucoma and cataracts and other types of diseases that are also able to be detected just by visiting your eye doctor, including associated diseases such as diabetes and hypertension. For Primary Care, I'm Dr. Lonnie Joe. Thank you for watching.